language, whether it's in clinical trials or guidelines for presentations. But more recently, I don't know if you guys are aware of the, I'm trying to share it, of this website, the Common Cancer Testing Terminology. It was a group of all these different organizations that got together and, you know, really were looking at the different languages, the different terms around testing, and whether germline or somatic or DNA. I mean, all the different genetic testing that they talk about, and they realize that there's a desperate need for a consistent language. And so within the lung cancer space, especially, what I'm familiar with is patients have get really confused because they could say, oh, you're having genetic testing, molecular profiling, biomarker testing, you know, and when different doctors are using different terms and patients are going for second opinions, they are just totally thrown off, and it's very overwhelming. So but this group of 40 patient advocacy organizations got together and they created this white paper and this website. And so, whoops, what did I just do? Sorry, can you see? Can you guys see it? Why is it blocking? Okay,
I can see.
So they got together and they created a white paper, and I don't know, it's here on the website if you want to look at it, but they also did some infographics. And so, for instance, here's an infographic on 40%, you know, just some of the highlight of testing rates and some of the different ways of adopting consistent common terms for patients. And I think that the woman in the lung cancer space from Longevity, I was talking to her about it because I had given a presentation during ASCO Education on patient-physician communication in the era of precision medicine. And I brought up, you know, this website and this white paper. And she just said that if you guys, any advocates or group of advocates want to use the platform or use anything to create your own educational materials, let us know, we can help you. And so it got me thinking more about just in general. So ASCO came out with the respectful guidelines. We all saw that. I'm on a, I guess, focus group, working group, whatever you want to call it, with patient-friendly language in clinical trials. The FDA is trying to work on changing some of the terms that they use. I am on a committee that's changing, well, we're creating guidelines for the International Association of the Study of Lung Cancer for them. I think we're going to start with for presentations for, you know, in guidelines that are patient first, that are consistent, plain language, and so keeping it simple, those type of guidelines. And so anyway, so I just started thinking, I know lung cancer isn't the only cancer that really has had a hard time with some of the language used. And I didn't know if there was a way or if anyone was interested in, you know, making a collaborative that principles or guidelines for language. And I think, you know, it doesn't have to be difficult, but guiding principles that with the group, with the audience, I'm not talking about necessarily our patient audience. It could be the oncology audience and what we would like to see or hear. And so, I mean, there are so many, you know, I could get deep, you know, go down that rabbit hole, technical rabbit hole of words used. We, you know, could talk about the types of language, like I said before, you know, stigma free, person first, non-judgmental, focusing on strengths. So many different things that can be done, but I wanted to just like kind of gauge if people were interested, if people think that that would be a valuable resource, and whatever, you know, any other thoughts that anybody had.
I love it, which is why I got excited that you were going to share it. I know that, you know, in the current cancer communities, we already talk about how important word choice is, and how words matter. You know, if you spend any time on Twitter, you know, there's always kind of the debate around battle language with cancer. And I think that's, you know, a lot of those are personal preferences. But I think when it comes to terminology like this, mixing those terms is actually gating to people developing personal health literacy, you know, their own disease literacy, communicating. There's huge barriers even when you talk outside of the clinical aspect of it, but communicating to payers. Right? What is genetic testing? What is genomic testing? What is biomarker testing? And why the heck is it so important? So on a personal level, I have a tremendous interest in trying to get everybody on the same page.
So yeah, and I think like I'm trying to find this. Can you see the Word document?
Yep.
Okay.
The results of the poll?
Well, you don't see a Word document, you only see the results of the poll. Okay, that's fine.
Yeah.
So this is the poll, I'll go through this is the poll that they took originally. So they originally asked, how did you learn about a survey? So then they went through that, but then how familiar are you with each of the following terms as it relates to cancer? And you could see there's a lot of yellow there. So, you know, genetic testing, but great. When you look at that further, genetic testing for what? So this is all the types of genetic testing, right? So I don't know about you guys. I mean, I know in lung cancer, genetic testing, immediately they think about breast cancer and BRCA gene. So, you know, and that's genetic testing for a risk factor. And it's, you know, an inherited, not a somatic mutation. So it all gets really, really confusing. And so, you know, that's one of the things that I think is I think physicians need to be really careful with the words they use. There was one other, they did this health provider card for, you know, physicians and the words that should be used. So biomarker testing was the common term that they came upon. And I really like that term because it encompasses any biomarker. I mean, you know, a biomarker can be, you know, like, again, in lung cancer, it could be a mutation, it could be a fusion, it could be a PD-L1 expression. That is a biomarker, where if you use, and it's a simple word, it's not molecular. I feel like molecular people get, ooh, I don't understand biology type thing. So I agree. And I also think that, you know, I think that, I just think that if we could, whoa, where is that? I I didn't, I thought I pulled up something else, but I can't find it now. But again, like if you look at, I think when you were talking about words, Stacey, or phrases, it's like, you know, when people say, oh, you're a smoker. Well, that's you know, it's a person who smokes, not a smoker. Or, you know, when they use the words like chief complaint, when it's really a concern, a patient isn't complaining, or non-compliant. Well, how about the patient is unable to do this because of these restrictions, or, you know, as you know, the patient progressed, or the patient failed treatment. I could go on and on. So in those, I guess, are really what the common, maybe what I guess the common terms that are pan cancer across the, if you're talking about language. But I think there's no other way to kind of shift that culture. Like, I think we as a group could probably do that.
No, I agree. Some people are really good at raising hands. Annie, are you trying to
Yeah,
say something?
I was just going to say this is a really timely discussion, especially with, you know, I think it's Keynote 158, where now the FDA approves, you know, last line Pembro for TMB over 10. Like, people are asking a lot of questions about tumor mutational burden testing and NGS and liquid biopsies and ctDNA. And, you know, we just been having a lot of stuff in the colorectal cancer area about KRAS as a driver mutation, because it's not as much of a driver mutation in CRC the way it is in pancreatic or lung cancer. And so people are freaking out because, you know, the stuff is saying it's a driver oncogene, and it's like, it's not as big of a driver as BRAF, or it's pretty, and anyway, it's just, it's a really big issue. And just as one example, somebody I know was in our MSI group, trials group in Tom's in Colontown, and she was there for a good 2 months thinking she was MSI, and she was actually MSS. And 95% of colorectal cancer patients are MSS, and, you know, their response to immunotherapy is quite different than people who are MSI. So it's because the pathologist report, it's not just the oncologist, the pathologist report is crazy, you know. So anyway, I'm not sure what it is for like PD-L1 expression in lung cancer, but pathology patients and oncology, it's really difficult to read some of these things. And even things like KRAS wild, it's like, I
Right.
cannot have another discussion about KRAS wild in my lifetime.
Yeah.
Why do they,
But
why
I
don't they, yeah, why do they even use that? It's so ridiculous. But yeah, yeah. It's
So everything you just mentioned, like, I'm familiar with, I think a lot of us are familiar with, but I think that's the point. I think that it's all those words we get, but if we want to develop something so that the lay public will understand that, I think it would be very, 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 like, beyond helpful, because I get questions all the time, and it would be very nice. Like, I don't know if we would want to maybe work in smaller groups and or just more broadly, but I think that developing like exactly what you showed us, stuff like that will help when we're reached out to as advocates to explain some of those things without being too scientific. Because like I said, a lot of us have educated ourselves and know about a lot of that stuff, but
Right.
the majority of those words that you just mentioned, Annie, I want to say 90% of the colorectal cancer, you know, the other patients that I talk to have no idea what any of that is. And it would help them ask the right questions to their doctors.
So then do you think it would be more of a creating something than for the patient side of things, as opposed to asking for these guiding principle, or I mean, it could be both, but guiding principles when talking with or about people living with cancer?
I mean, I think it could be both, right? I think you have to start with the patient to feel empowered to ask their doctors, but then you also have to provide doctors with tools as well, right? I mean, I think they don't necessarily know the right things to ask. So if they have like, an information card about what liquid biopsy is or genetic testing or all that sort of stuff, then that would be helpful for them, but also then for the doctor, maybe this is the term you should use with all of your patients would also be helpful for them. So I think it's a two-way street. I think, this could benefit both. We just have to, it would be different. The avenues would be different for patient versus medical professional.
Can I just bring up one thing when we talk about this, and I love the openness to do a both and, but I think we also have to figure out where the pain points are. We understand where the pain points are in the patient community. I will tell you, I know that there are pain points in the clinical community too. A lot of us are dealing with oncologists that are deep heads down in the precision medicine space, but a lot of oncologists are not. And so they too are finding themselves kind of overwhelmed, and, a mixed bag of verbiage, words that mean similar but different, is also challenging. So I would actually think that we could consider prioritizing the patient needs, right, and kind of our community. But I think we could influence a little bit of how these terms are used in the clinical realm just by addressing the fact that, hey, this is a problem for your other stakeholders as well.
Yeah,
that's a good point.
I just kind of want to jump in. I'm also cooking, so I'm trying to find a time when I'm not making too much noise. So I used to be a molecular biologist, so all these terms, like for example, wild type, there is a reason why it's used for unmutated, but the terminology just got transferred to the clinical space. And, like what Stacy and what Jill was saying, there needs to be training to both patients and oncologists, because writing wild type is all good with respect to terminology, but it's so confusing to patients. So the oncologist could make a note saying this is unmutated or normal. That would help a lot. And then in the CRC world, you have MSS and MSI, and nowadays they write MSS unstable, which is really confusing because people think that's MSI, and it is MSI, but they should not write MSS unstable. They should write microsatellite unstable. So things like that, and these kind of things. I mean, I like the idea of having some kind of a governing or guiding principles, because then that would take care of these terms, and to say that you bring things from molecular biology, it's all good, but when you're talking to patients, maybe you should write it in a language that is not confusing to patients. Forget about what is the terminology that is standardized in the research world. We probably don't need that in the clinical world. Or when oncologists explain this or give their reports back to patients, they could say, in simple terms, this is what it means, and that would help greatly. And I like what Stacey said, except for a few doctors who are in the precision medicine space, a lot of the other oncologists don't understand these terms as well. So that makes it even more confusing for them. So that's why maybe addressing it with both patients and providers are important. Okay, I'll stop now.
Wait, can I add to that as you're saying that, though, because you made some great points. And, the other group would be industry for the words. Government would be ideal, but definitely industry. And I think that, and I like that idea, what you just said. And Allison, starting with the patient and then pushing out what we're using to these different, to the physicians, to industry. And I don't know if anybody could think of anyone else that just came to mind.
Can I ask a question? Because when you were sharing about the common cancer testing terminology, the site that you shared, I'm in a committee with FORCE, and I heard about this, and they have now other groups working in, and I missed the meeting, so I cannot tell the details. But what I want to understand is that going to be what we're going to use as a base? Because they have this white paper, and when I was in the first meeting, they explained, you know, how they got together, and I raised the question because I'm Hispanic. When you go even to language, that's a whole other issues, because we have a lot of as English as a second language in the United States that they don't understand nothing. So, and it's a cultural thing. I just spoke to a lady a few minutes ago that she called me because her mom was diagnosed, and they were giving her some pills to disintegrate the tumor. And you know, they talk, they don't even know what they're saying. And so when you go into terminology, that's another ballpark. So anyways, I just want to see, you know, where is it? Because you presented this and I know it exists and I heard of it before, but for four, so where do we go from here?
So yes, and you know, you bring up a good point with language barriers, and obviously I know we're all very, you know, very determined to reach underserved communities as well. And I mean, I think we could do that. I think we need to first do it at the level we can do it, and then for the language barriers, translation, I believe they did talk about that as well. And then the underserved communities, I know they talk about in the group, they've talked about it in the group as well. And I just totally forgot, and I don't know if anyone is interested. If anyone from this group wants to join ACE, if anyone from ACE wants to join the group, the coalition, then, you know, she said that they'd be happy to have somebody as a representative of this group. So, you know, nobody has to raise their hand right now, but yeah, it was just, I guess, going back to your question though, Barbara, it was more of, hey, we've created this. We have action items moving forward, what we want to do. If there's ever anything that advocates want to use it for, let us know, and we'd be happy to support. So it was more of just kind of that type of conversation. And I thought, you know, I mean, anything that we all have different cancers. We're all working on different things. Even within our own cancers, you know, there's different groups. And anytime there's an opportunity to collaborate, I just think it's powerful. And this affects all of us, testing. And so, and it's only going to affect more and more cancers as, you know, time goes on. So it really is an open-ended invitation, and I believe we could kind of we can use their stuff. We have to figure out how, but we can build upon it and, you know, kind of with our own ideas.
Jill,
Yeah.
I wanted to ask a question.
Exactly my point, in terms that instead of reinventing, and that's the good thing about collaborating. If somebody is here and we still have to get to this other part, we already have the base to really model it or have it more for patients or for physicians. So.
Mm-hmm.
Jill, it's Grace.
Hi, Grace.
How are you? I'm listening to everyone's feedback, and what I'm seeing is there's definitely a huge unmet need with describing the markers. And I loved how you described even BRCA versus a targeted mutation or something that could be treated potentially. I'm seeing a visual abstract, a picture that can be easily shown as a tool that describes, even side by side, like just the example of something hereditary versus something that's an actionable potential treatment target, and then listing all the different types of mutations, locations in the body, because then that visual could then also be easily translated. But you also have this whole concept of the words we use matter. I'm seeing that almost as a separate something else that I run into with patients is when they want to go for testing, they don't know what the testing is. What's the test that goes with this mutation? How do you ask for it instead of sitting there fumbling? Well, can I test? Not every organization has a specific test. Someplace like Sloan might have their own internal lab. So it would be nice also with the mutations to have a test to ask for, or a reference or something that describes what makes that test special, or why is the MD Anderson one better than Fox Chase Cancer Center or not, or they're the same.
Right. Right.
I love what you're bringing up there. I don't know that there's a solution, because there's actually no data that says one diagnostic panel is better than another. But I think it's a great call out, is that there are so many different levels of confusion. And if we could just address the most basic level, which is like when somebody says biomarker testing, what the hell does that mean and why is it important? Like if we could arm every single individual who has a cancer diagnosis with something, regardless of what their cancer was, to say, have you asked about biomarker testing? It's generic enough that, you know, it's applicable across the board. Individual cancer advocacy groups could take it, they could modify it, they could make it very, very specific for the actual biomarkers that needed to be tested. But this general piece of education would be enough for a patient who might not have a physician or a medical team well-versed in precision medicine to at least broach the question, and then to be able to answer the follow-up question, why do you want that test?
Mm-hmm. You know, I love the point. Thank you, Stacy, for emphasizing that, because I find that oncologists at respective facilities will say, well, our test is better. So I find that an interesting point, because then people get stressed if their insurance doesn't cover that specific test, and then they don't get the testing at all. So that's actually a really strong point. I'd love to emphasize that, because how would you know? You're going to go by what your care team knows.
And by what insurance is going to pay for.
Yeah, exactly. And we have a biomarker summit next week, and one of the biggest topics with NLC, with National Lung Cancer Roundtable, and we just had a call, and one of the biggest topics was payer, and which, you know, that I think it should be a policy thing, but I think part of it is the patient not being educated.
1 minute, okay? Can you turn it on? Oh, sorry.
Can I just share something that somebody brought to me one time? Because I started the small organization. I was doing all the writing, and I'm pretty folksy anyways in my writing. I write like I talk. But she shared with me the CDC has some health literacy tools. And so, okay, some of you are nodding your heads, which are really good. And so I always feel like anything that I write or anything that I come up with, and I can tell you in the world of ovarian cancer, it is really important right now that, and I was using genetic and molecular profiling. And now I would like to adopt this biomarker testing, but I still want to make sure that patients know that they need to have genetic, right? Because it's treatment. So some women with ovary cancer have BRCA mutations, right? Genetic mutations. And then there are some somatic mutations too. You can have a BRCA somatic mutation. So, you know, just running some of this stuff through those health literacy tools, because I found, even as folksy as I am, I was too, kind of like I'm talking right now, too much.
Right. No, you're not. No, but
the point has been made.
But you know, and I think that's a really good point, because I think really biomarkers should be across every cancer. So I feel like, and I'll tell you why, part of it is pathologists in reports. I mean, we're starting at the real small granule level, right? So, but when it branches out, we really, we want the reports to reflect that. So when the patients get the reports, they can read that as well. But I think your point too, and I think that's something that they did, which I loved, was they took genetic testing and they described, the germline or inherited versus somatic. And then they even broke it down like genetic testing for an inherited mutation, genetic testing for an inherited cancer risk, genetic testing for hereditary, and they really broke it all down to look at which terms should be used. And I think that is something that could be spelled out and defined.
Yeah, in our CRC world, what I try to say is I don't like the word genetic testing because it's very commonly confused with genomic testing. So I use these two terms separately. I say what is applicable to the vast majority. Like for example, only about 3% of CRC is inherited. So I say that for the vast majority of us, everything is genomic testing. And genetic testing is just, for inherited things. That's different. And then with the genomic testing would cover everything, right? In India, in the genetic situation, they are looking at genomic DNA from the normal tissue, and tumor testing, they are looking at genomic DNA from the tumor tissue. Then I try to explain that genomic testing can be somatic versus germline. In that, I feel that it covers most of the things. And that's again the confusion because it's so misused. The terms are so interchangeably used that it breeds a lot of confusion.
And that's why biomarker, because what a discussion that we've had in the lung cancer world is when you're looking at a PD-L1, that's really not genomic testing. So it's a biomarker though, and people need to have their PD-1, PD-L1 levels tested. So yes. When people, I don't know about other cancers, but so there's a situation where it doesn't fall under a genomic testing situation. Yeah. But biomarker testing as the umbrella, because
yes, I agree.
Do you know what I'm saying? Yeah.
Yes. Even ctDNA would be under biomarker, and that's not genomic testing. So, and then for us, the only other thing is that in the CRC world, when people say biomarker, they automatically think it's something like CEA. So, because that's the most common biomarker that's used. So then you have to say biomarker can be anything that tells you about your tumor. It can be protein, DNA, ctDNA, RNA, whatever else, something like that. Yeah. And then I just want to mention one more thing. So in Town, what we have started recently doing is we are compiling a list of all major testing companies and kind of making some kind of a cheat list for people, like say your stage 1, what kind of testing is applicable to you? Your stage 2, what is applicable? For stage 3, for stage 4.
Mandy, you just landed yourself on the presentation calendar. That's brilliant. Seriously, I'm not joking. Sorry.
Yeah, but doing it this way, then that gives a good idea to patients, like what can they do? Because some testing is applicable to everybody, but some testing, like we have now what is known as minimal residual disease testing. That is mostly applicable in the early stage cancer setting, and also in the case of stage 4 patients who have done, who have undergone anything curative, like a curative surgery or some procedure which people think would cure them. In that situation, the MRD testing is applicable. So we are trying to do that, and we have not introduced it to patients yet, but once we have that, maybe then Stacy, depending on what, how useful people find it, then maybe we can give a presentation.
No. And I don't want it to feel like pressure. The reality is it's not usable for every community. What you're creating is going to be very specific for the colorectal cancer community, which is great. I think what this group would benefit from is understanding what the need was, because I think we all share that need, and how you chose to address it, which is what you were kind of just explaining, and then the tips and tricks you have if we in our different cancer communities were to try to do the same thing. What were the pitfalls? What were the challenges? I just, as you were talking about it, I'm like, oh, duh, that's fantastic.
Yeah, and we're trying to address some of the payment things, and we're even trying to reach to companies and kind of trying to find out, because some of them have like these open access program or expanded access program, which they're running for a certain time. And during that time, like for example, when I got testing done, because my insurance didn't cover it, I had to pay nothing. When insurance covers it, then my copay would have been like $150. So, getting many patients to test during that time period was great for patients, right? You don't have to pay. But once it gets through the approval, then you have to pay. So that's what we're trying to kind of maximize, the time period during which these companies are willing to do it for free, and then have as many people tested during that time. So
I just want to add something if I could. My name is Amanda. I'm a current cancer patient. I'm actually going to be doing the World Oncology Conference, the summit in 2020. It's supposed to be in Dublin, Ireland right now. It's a webinar. My abstract has been posted already. I'm doing like cancer awareness. And in my speech, I said, like for cancer awareness, if someone in your immediate family is diagnosed with cancer, why is it not applicable to give the daughter or son a genetic test to see if they have those gene markers or mutations or biomarkers of any other cancer? I don't understand why it's not, like it should be. Well, I'm in the United States, so why is that not given to people? It's part of prevention and awareness. Why are people not, why don't they know about genetic testing, or how come it is not, talked about enough? And also, when you're given a paper that says you have this mutation on it, like everyday people don't know what those things mean. So I think it would be wonderful to talk about these points like in my PowerPoint that I'm doing. And, my biggest question is, how come we're not talking about this?
Well, we are. That's why we're talking about it right now. And Amanda, thank you. So for those of you who didn't catch it, Amanda just joined. She's one of the handful of new people who just joined. So Amanda, a lot of us are talking about it in our specific advocacy communities, and in the breast cancer space, in the lung cancer space, in the colorectal cancer space. This is really, as far as I think however many of us are on the call know, this is really our first opportunity to come together formally across the different cancer spaces and talk about what's a common problem. I mean, there were things that the lung cancer community will deal with, and it's kind of unique to their community. But there's a lot of things that we deal with that are not unique. And so that's the point of this whole shebang, is to come together and say, how is it affecting you? Is it affecting you in a similar way? And if it is this a gap that we can try to fill together? So.
Yeah, I think that was, oh, go ahead, sorry.
I was just going to say,
going even one step ahead of what you're saying, because we were talking about maybe someone understanding that the family member was BRCA positive or whatever. What I find, especially and I can talk about Puerto Rican or Hispanic population, that people don't even know the different cancers the family had, the family history. So I think we should start with the general community, just thinking, because when I sat with my oncologist, he had all this and said, okay, you have a brother, a cousin, and he did all this map, and he said, okay, this is the testing that you needed. But I was informed enough and had the questions. But when I started, learning as an advocate, is not only what type of cancer, when it was detected, what treatment, what age it was, and all those things that common people don't even understand. So it's, we even have to let the general public understand and sit when your parents still have their mind in their, to talk about their relatives and all those things, because otherwise people don't even know they are at risk, not even let alone to ask for a testing. So I just want to.
Yeah, and that's where, again, going back to, you've got, you know, talking about testing. And so I think having a general, you know, when we talk about the genetic testing, again, talking about genetic testing for an inherited mutation, genetic testing for an inherited cancer risk. And so we get those terms general, and then in our own communities we break down what that means. What does that mean in ovarian cancer and breast cancer, colorectal, lung, you know, melanoma, go on and on and on. And I think that that's exactly what we can do with it. I think our group could really create that base of question or of language.
And can I break in?
Oh, sorry. Go.
I've had my hand up for like 10 minutes. So I've been filling shit into the chat thing. But, you know, I got sent to a genetic counselor because, you know, getting diagnosed in your 50s, he considered early, the surgeon. And what the genetic counselor said is that where we are in colorectal cancer is sort of where breast cancer was 10 years ago. And what she advised is that I always keep track of that genetic report. If I leave Kaiser, make sure that they know so that they will keep me updated on any changes. Like for instance, an NTRK mutation, there's now an FDA approved treatment. And so I think somebody was talking about seeing a chart. Like I think having, what do they call those? The sort of the algorithm of, you know, sporadic or genetic. And then, you know, if you're genetic, checking in with your family, doing a family history chart, you know, letting people know about testing, maybe getting into like a Lynch family registry. So there could be an amazing algorithm and sort of a general one for all cancers, and then getting really specific for within different tumor types, you know. So even though it's like, if it is sporadic, it's going to be one set of things, but if it is genetic, there's going to be a lot of similar things that people will go through.
Yeah, I wanna do a time check because we're almost at the top of the hour. And Jill, thank you for kind of putting this out there and generating the discussion. I think that, you know, some of us have been pretty vocal about the fact that we see this as a need, and we all have a lot on our plates. So if you think it's a need and don't have time to spend on it, full respect. But I just want to talk about kind of next steps, because Jill, what I'm hearing is that we could reach out as individuals and become part of this already existing consortium. It also felt to me like in our initial conversation, we could reach out as the consortium and say, you know, the Advocate Collaborative as a group of us is also interested in participating. And then I don't know if that's accurate or not. Is that, you're on mute.
No, I think that is accurate. And what I can do in next steps is I can reach back out and I could say, you know, we had this robust discussion. So we don't know what it looks like, but we'd like to maybe continue the discussion and figure out, you know, I mean, I could have Nikki join us one time, or, I mean, people can think about.
That would be great. I mean, I think, you know, inviting her to join us. I'm also, you know, if we are interested in participating, can you, do you have the bandwidth to kind of take all the people's names who are interested and we can work out something? Because again, what I'm feeling is that this almost feels like a little bit of a subcommittee, people within the collaborative.
Right.
That
so
are interested.
Yeah, maybe we could, and I don't have to even, I mean, if somebody's really, really interested in it and wants to take the project on, or, you know, as a lead, I'm happy to let someone do that as well. If someone's interested in being on their or their group. I think they're called working group or whatever they're called. I don't know. Anyway, let me know. And yeah, so I guess.
Why don't we do this? I'll put out in the notes from this meeting that we're going to form, a small little subgroup of people who might be interested. And just like this main group, it's whatever you have time and energy and interest for. So if you're interested, but another meeting isn't in the works, that's okay too. I think we need to make a decision whether or not maybe we want to have one individual represent this group, but I also don't want to gate anybody. So if somebody just says, yeah, on a personal level, I want to play, more power to you. But I really would love to have an opportunity to bring this larger group of, 80 of us now together to kind of weigh in. And to Barbara's point, respect the work that's already been done, not recreate the wheel, just be able to help support that same effort.
Right, right. And they have some great, take a look. I know I brought the website up. I don't even know.
Yeah, I haven't looked at it.
Let me,
and there is also this other group for TMB, like Friends of Cancer, something like that, because TMB, how it's being done seems to be so much variable between different companies. And that group is trying to standardize how, TMB testing is done. So they have some seminars and things going on. So it'd be kind of good to in some way, all of this can be linked.
Okay. And what we can do too is I can put the link to this common cancer testing terms in the email. And again, if people want to join as part of this group, or if people want to join individually, that's up to them.
Okay, and I'll reach out to Nikki in the meantime and just get some more information. And then I can, after you send that email, or I can send it to you before you send the email.
Okay, perfect.
Let me do that. Okay.
Perfect. Thank you so much. Thanks for jumping in and sharing this with us. And thank you all for joining the call. And it looks like we're...
Because I'm a little technologically challenged. So how do I get the notes from the chat? Do those save?
I just saved them. You can also save them if you don't trust me, which is sometimes wise to not trust me. But if you go down in the chat, there are 3 little dots and you can save chat.
Oh, okay. Save, just push that. Okay.
I know, like life hack, right?
Wow. Yeah, never knew that. Okay.
All right, wonderful to see you all. Thank you for joining. Stay safe from hurricanes and fires and smoke and whatever else we got going on. Bye.